top. We did, got it. We did the two upper limbs. So we started with the brachial plexus, and then we did the nerves of the upper limb, and now we're going to do the lower limb. And what I ask is, again, to remind you to study things by their movements, okay? So in the lower limb, it's very easy. We're going to talk about 10 movements. So this is what I owe you. By the end of this day, we're going to talk about 10 movements. 4 movements of the thigh, 2 movements of the knee, and 4 movements of the ankle, okay? So that's what I owe you guys. I owe you hip flexion, hip extension, abduction of the hip. Those are 4 movements. The knee is obvious, extension and flexion. And then the ankle is a little bit more complicated. We have the dorsiflexion, plantar flexion, inversion, and eversion. Those are the 10 movements. And then there are going to be 2 reflexes. If you know those, you will know how to localize lesions that go to the leg. Okay? So just to simplify. So, oh, it's working. All right. So a few things before we get to the actual nerves. Let's start with roots. Now, if you remember, when we started the series, we talked about nomenclature of how roots are named. And if you remember, we talked about the fact that in the cervical spine, the roots are named, so the number of the root corresponds to the vertebra below it. So C1 is above C1, C2 above C2. And then at C8, it switches because we don't have the C8 vertebra. So on the upper part of the spinal cord, the roots are named, like the root number is above the corresponding vertebra. Here at the lower spine, it's the opposite way around. So L5, for example, comes below the L5. So L5 root comes below the body of the L5 vertebra. So that's point number 1. That's very, very important to remember. And then there are a few more things to point out. So here we have the vertebra and the disc in between them. I don't know if in Zoom you guys can see the pointer. They can? No. Okay, so the vertebra in between the disc. But what's important also in terms of structures is that anterior to the vertebra, we have the anterior longitudinal ligament. Can't see what?
I guess the sharing is not right. First, which box? It's hard to see. Here. No. This one. This big, I can't see. Okay.
Right. Hopefully we'll get to 2 movements out of the 10 by the end of this. All right. So back to our show. So we anteriorly to the bodies, we have the anterior longitudinal ligament. But what's important is that it's cut off. Let's see here. How do I get rid of all this?
Oh, there. No, maybe you're drag it. Yeah.
It will disappear. Okay. So okay. So if we have anterior longitudinal ligament, that means that we have a posterior longitudinal ligament. But here I want to caution you, the posterior longitudinal ligament is actually in front of the spinal cord and the roots in the canal. So it's a little bit confusing, the posterior longitudinal ligament. I wouldn't mention it unless it had a very important role. So the role that it has, so these ligaments actually hold the spinal column together. This is not, it's not disappearing. Robbie, can you take care of it? What's important about it, aside from the fact that it's keeping everything together, is that it's actually keeping the stacks of these discs aligned. So basically, no, it's not. It's still not here. No. Just try to minimize it. So basically what it means is that this strong ligament, the posterior longitudinal ligament, does not allow the movement of the disc to go directly into the canal. It's basically affecting the canal, the cylinder, but can they still see the line?
Yeah.
Okay. So this is very important. And the only way for a disc to actually bulge in centrally to the canal, which would cause cord compression, is if we had a tear in the posterior longitudinal ligament, which could happen, but it's only in situations where there's a huge force, like a motor vehicle accident or huge trauma. The degenerative changes that people get don't cause a tear in the posterior longitudinal ligament. So therefore, basically the discs are protected from going directly into the canal, okay? So that's another point, a structural point to remember. Behind here, we have another ligament, it's the ligamentum flavum. So just remember the posterior longitudinal is actually inferior to the neural structures, and then in the back we have the ligamentum flavum. We also have the facets. All of these can hypertrophy when we have degenerative changes. So the ligamentum flavum can enlarge, the facet, the joint here can degenerate, and then all of this can cause constriction of the canal, what we call spinal stenosis. Now, the roots themselves, they come out of the canal in the foramina. So between each two vertebrae, we have these foramina where the nerve roots come out, and they're, you know, unless they're impinged, there's no problem, but obviously the degenerative changes can impinge on them. That's what we have what's called a radiculopathy. In terms of orientation, it's important to kind of try to orient ourselves in order for us to number the vertebra, so then we can call the roots by name. So we should identify here the first sacral bone, so that will be S1, which means that above it will be 5, 4, 3, 2, 1. And that's helpful in terms of the other relative structures. You can see here the conus of the spinal cord, which ends around L1, L2, and then it becomes the cauda equina, which, to remind ourselves, these are actually nerve roots. These are lower motor neurons that are still in the canal, but these are lower motor neurons. And here we can see on the bottom, in the myelography here, the actual roots here, the cauda equina. Okay, so in terms of importance of these structures, not moving. Okay, eventually. So disc herniation is a very kind of important concept that I want to bring up, not because of the pathology, because this is not a pathological discussion, but more because of the anatomy. So like we said earlier, central disc herniations or midline disc herniations are actually rare, and they are very dangerous when they happen. But they're part of trauma because you require the care of the posterior longitudinal ligament. So those are rare, but when they happen, if they happen on the cord, you can get cord compression. If it's in the conus, you can get conus medullaris syndrome, which the patient will have initially flaccid paralysis of the lower limb, incontinence, and later on they will develop spasticity. If it's a little bit lower and it's compressing the cauda equina, then you'll have cauda equina syndrome, which is very similar to the conus, except that the flaccid paralysis stays flaccid, reduced reflexes, no spasticity, but you do have incontinence. So that's kind of rare. But then we have two other types of herniations, the more common one, which is the posterior lateral, and then we have the far lateral. So how do they look like? So here we have, on the left, we have the more usual posterior lateral disc herniation. So that you see this bulge here. So this is the disc, and there's extrusion of the disc matter into the canal. So this is the more common type. And then we have another one, which is the far lateral, which you see it's more lateral on the side. Still a disc, but on the side. So it's not in the center, but more on the side. So why is it important? Well, it actually turns out to be extremely important because of the structure of the spinal canal and relative to the root. So here we have the more common posterior lateral, the one that is more medial. This protrusion, you see here, bulging here. Turns out that when it bulges here, and this is between L5 and S1, when you get this extrusion of the disc material, when that happens, it actually happens below the corresponding root that exits that foramina. So the root that exits that foramina, L5, already escapes. You say, okay, good, then nothing happens, there's no problem. The kicker is, yes, something does happen. What this does is actually it impinges on the next root. So the next root here, that's one in this case, although if the exit is far away, is actually impinged over here by the more medially located disc extrusion. Now, the far lateral, the ones that are more on the side, they actually do catch the corresponding root that comes within the foramina. So what does it mean? It means that when you have the more common type, you always have to remember that it will impinge on the number below. So let's take, for example, this one. It's between L5 and S1. It will impinge on an S1 root. So a disc between L5 and S1, the most common disc between L5 and S1, will cause an S1 radiculopathy. It could cause a L5 radiculopathy if it were far lateral. So here in this case, between L4 and L5, it will cause an L4 radiculopathy if it's far lateral. Okay? So the way to remember it is the most common disc will impinge on the lower number. So between L4 and L5, you'll have an L5 radiculopathy. Between L5 and S1, you'll have an S1 radiculopathy. That's the most common case. Now, just so this is schematically, but just to show you that this is not just important for our patients, but also for your board and exam. So here we have question number 259, right? And here we have a patient that comes in with back pain and a dropped foot. Now, you don't want to send them to the surgery of the wrong disc, right? Because we see that we have a protrusion here. This is S1, this is the body of L5, and this is the body of L4. You see here a large extrusion of this material between L4 and L5, but you see also a small disc between L5 and S1, right? And the question is, what do you tell the surgeon? right? The patient has a dropped foot. Now, in a moment, we'll see that L5 impinges can cause a dropped foot. Right? So the question is, where is it impinged? Now, if you look at this, only on this image, you can't really tell, right? Because what I just told you earlier, it depends if the disc is impinging on the medial aspect or far lateral. Now, because it's impinging here, it's the usual type of disc, which is the posterior medial type. This is the type, as you remember, that impinges on the neck. Okay? So in this case, we know that the culprit, the problematic disc that needs to be surgerized is this one. Why? Because if the patient has a drop foot, we'll see in a moment that L5 will cause a drop foot. Now, who impinges on L5? It could be a far lateral disc at L5 space, or it could be a central medial one, posterior medial one from the disc above. So between L4 and L5, it will catch the L5. So remember the lower number between L4 and L5 will catch the L5. That's what we have. Okay? Is this clear to everybody? If this is very common, and also you don't want to send the patient to surgery on the wrong disc. In this case, it's very clear. This is kind of a large disc, you kind of suspect it, but sometimes you have an extrusion here and a large extrusion here, or maybe even larger, but maybe it's innocent. Okay, so it's important to know to send the patient to the right surgical intervention. All right. Now the plexus, and I know this looks like a bunch of spaghetti here, but as I said, we're going to simplify it to 10 movements, okay? And so we're talking about the lumbosacral plexus. So we're talking about roots that come from the lumbar and the sacral spaces, which combine together to become the lumbosacral plexus. So we have the top roots coming from the lumbar, and then we have the lower roots that come from the sacral roots, and in between them, we have what's called the lumbosacral trunk, which we'll get back to in a moment. All right, so let's start with the upper part of the lumbosacral plexus, and here we're going to talk about one sensory nerve, and then 3 movements. All right. So we'll start with the sensory nerve. Very important because you money back guarantee, you'll see this patient very often. Patients who come in with sore or numbness or paresthesias in the lateral side of their thigh. And the reason for that is impingement of the lateral femoral cutaneous nerve. And here we can see it. The lateral femoral cutaneous nerve. Now, several things to say about it. First of all, that it has nothing to do with the femoral nerve except for the commonality of the name. It's not coming off the femoral nerve. It just goes into the femur area, okay, to the leg. The second thing is that here it passes underneath the inguinal ligament, and if there's pressure on it because of weight, because of obesity, because pregnancy, or because the person flexes their leg a lot. For example, I had a patient who was a professional biker about this, which I told him that he should probably not bike, so that was a lot of time. It's not dangerous or anything because it's only sensory. And this is actually very, very important when you see a patient like this. It's very, very important to do a very good exam to make sure that there's no weakness. Because if you do see weakness, it is not a lateral femoral cutaneous nerve impingement. Because this is a pure sensory nerve, self-limited. Obviously, with pregnancy, it gets better afterwards. For obesity, you give the appropriate recommendation. And for settlers, well, depends if you want them to continue being your patient. They'll give them good advice. But anyway, that's a common thing, common problem, self-limiting. All right, but now we're going to talk about movement. So we're talking about three movements. We'll start with the iliopsoas muscle, which are the strong hip flexor. What we're talking about now, hip flexion. That's the first movement of the 10. Now, the muscles of iliopsoas are innervated by nerves that come off the femoral nerve. Now, this depends on different books. Some will call it femoral nerve, some will call it nerves of the iliopsoas. It doesn't really matter. What's important is that the source is from L2, 3, and 4. Okay, 2, 3, and 4. The majority of the innervation comes from 2 and 3. Okay, through these flexors of the hip. Now, the two other movements that we'll show in a moment, they also, which we'll name in a moment, they also share the same roots, 2, 3, and 4. And this is something we like, a situation where we have something in common and something uncommon. And this will help us differentiate where the problem is in our patient, as we'll see in a moment. But first, remember, hip flexion, it's kind of very proximal femoral nerve, L2, 3, and 4. And here we can see the takeoff here. And again, this is formally part of the femoral nerve, but in some books you'll see nerve to the iliopsoas. In some books, they reserve the term femoral nerve to the part that starting in the inguinal region, just because there's a lot of pathology that happens in the inguinal region or more distal, and would differentiate that from a problem of the nerves that go into the iliopsoas. So, which brings us to the next nerve that we're talking about, and that's the femoral nerve itself. So again, 2, 3, 4. And as you remember, it has kind of 4 branches here to the quadriceps muscles, which are listed here. And basically here we have movement that is not the hip, it's actually the knee, and it's knee extension. Now, this is another important concept that we talked about in the first talk, that for non-neurologists, they group things together based on location. You think, oh, everything innovative, the hip is together. No, here we see that actually involvement of the same roots, but a different joint. Okay, and that's helpful to know these things. So here we have a movement that is not in the hip, knee extension, but shares the same root. Okay? So think about it. If we have a lesion that affects both knee extension and hip flexion, it cannot be because of a distal lesion here only to the femoral nerve, right? Because they share together the roots on top. And to make our life even more easier, remember I told you that there's a third nerve that comes from the plexus. Also 2, 3, and 4. And here we have 2 branches, we'll call them together the obturator nerve. They share, again, just like the other 2, the roots 2, 3, and 4, but they do not go through the femoral nerve at all. Now, why is this important? The movement that they're doing in here, this is the second movement of the hip that we're going to talk about. In this case, it's hip adduction. These are the strong adductors of the hip. Okay. The adductors, they're innervated by the obturator nerve. Again, sharing the same roots as the femoral nerve and the part that goes to the iliopsoas, except that they're not the same nerve. Which means that if someone has weakness of knee extension, one of the important movements that you want to check is, do they have a problem with bringing your knees together? Because if they do, then you know it cannot be just a femoral nerve problem. It's more likely a radiculopathy. Everybody understand that? All right. So, just to show that this is not something that's not important, this is actually a common consult. We have this several times when we were called, patients after cardiac catheterization developed, weakness of, knee extension. Okay? Now, the question is in those patients that we see, so actually, we saw one that actually was, we saw that actually had involvement with the pace, and we not personal at all, probably stroke. But very often you don't see any other involvement, and you ask yourself, what is the problem? The problem is the femoral nerve. Remember, these patients are heavily anticoagulated, and they have a respiratory hematoma, which could plug the plexus, so everything is getting there to be affected. Or they may have what we found in this patient. Here's an MRI, an aneurysm and a bleed impinging on the nerve. Remember the vein artery nerve in the joint, they go into the artery. If that is ruptured and there's a bleed and the patient is anticoagulated, and you can also do, this is MRI, but you can also do an ultrasound, you can see swelling here, and that impinges on the femoral nerve. But that will cause only knee extension weakness. It should not cause excessive pain, hip flexion weakness, and it most certainly should not cause hip abduction weakness. So involvement of hip abduction weakness or flexion would suggest that this is not the problem. But in this case, it was a clear situation where we had fully isolated knee extension weakness. And those, a lot of times you just ask the cardiac fellow to put pressure, and if may resolve, or if you need vascular treatment. But it's important to do the anatomical, the neurological exam in order to help localize and direct further imaging. All right, so this point is here. One thing that I did not mention is that there was, aside from the movement, there was one reflex that is associated with that location, L2, 3, and 4, which is obviously the patellar reflex, which is done by the quadriceps. So it's another marker of involvement of the L2, 3, and 4 roots. Okay, moving along. So we talked already about 2 movements of the hip and 1 movement of the knee. So 3 down, 7 to go. Now we're going to mention a very important structure, which is called the lumbosacral trunk. Now you can look at, I don't know if I'm zoomed, they can see my hand. The lumbosacral trunk, you can look at it as lumbar and sacral area branching. And in the middle, you have L5, which is the lumbosacral trunk. So think about it like an eagle, and then there's the head. Now, why is the lumbosacral trunk important? The majority of the contribution to the lumbosacral trunk is L5. Okay? And there are a lot of nerves that go into the lower limb, which originate in L5. Okay? It's a very important group to remember. Then wake up. It's fascinating stuff. Can't imagine how can someone sleep through this. However, not only that it's important, it's actually very susceptible to problems. Why? And here we see the lumbosacral trunk on the rim of the pelvis. It's susceptible to pressure from above. So for example, baby's head can push on it. So prolonged labor with the large baby head, which will cause prolonged labor, can push on the lumbosacral trunk here, and mom will develop a blocked foot. Common concept. Usually self-limited, but this is where the problem is. Okay. So lumbosacral trunk, L5, mainly L5, runs along the rim here and susceptible to pressure. Common example would be head of baby. Okay? All the things that I'm telling you are scenarios from life and scenarios from board. Okay? The double whammy. Please remember. Okay. Now we come to 2 other movements of the hip. And those are small branches with very important functions that come off just below the lumbosacral trunk. We're talking now about the lower lumbosacral flex. Earlier we talked about the movement of the upper part of the which is close to 2, 3, and 4, right? We talked about those two movements. And then we talked about the L5. Now L5 goes and contributes to the lower part of the lumbosacral plexus. Now the first two branches that you guys need to remember are the superior gluteal nerve and the inferior gluteal nerve. Now the only reason that one is called superior and the other is called inferior is because the superior gluteal nerves hasn't the roots that contribute to it are above those that contribute to the inferior gluteal nerve. So here we can see the contribution. The writing, but if you see the top here, it says L4, L5, and S1. So those are the contributions to the superior gluteal nerve, 4, 5, and S1. Remember, this is the lumbosacral trunk over here. When you go on Zoom, you can't see it, but what I was pointing is the L5, mainly the L5 kind of, so L4, L5, S1 contribute to the superior gluteal nerve. The inferior gluteal nerve is just one root below, so it's 5, S1, and S2. Okay, so 5, S1, and S2. Now, why is this important? Because those are very, very important movements of the hip. Okay? We'll start with the superior gluteal nerve. The superior gluteal nerve here, remember 4, 5, and S1, innervates the gluteus medius minimus and the tensor fasciae lata. So those are our hip adductors. Zoom, I don't know, you guys can't see my ballerina dances here, but I'm bringing my leg outwards, okay? That movement of the leg outward in adduction is controlled by these muscles over here, innervated by the superior gluteal nerve, L4, 5, and S1. 4, 5, and S1, okay? Now, here's a way to remember the next nerve. The inferior gluteal nerve innervates the largest and strongest muscle in our body, the gluteus maximus. Okay, so remember, the inferior gluteal nerve innervates the largest and strongest muscle in our body, in our butt, which is important for our hip extension, which allows me to rise from the chair, to rise from the bathroom, to walk, all those proximal movements, to run from chasing a lion, right? And the roots that control it are the 5, S1, and S2. Notice that the growth between the L5 plays a role. That will be a common theme throughout the lower leg. So pressure on the lumbosacral trunk can cause a lot of weakness. Okay? Not just drop foot, as we'll see in a moment, but also problems with the hip movement. And again, I'm talking about weakness, which is not pain related, neurologic weakness. All right, so think about it. We did already 4 movements of the hip, right? We did the flexion, extension, adduction, and adduction. And we also threw in 1 movement of the knee. So we're halfway there. What time is it? All right, so we have 6 minutes to do the next half of your life. All right, no, don't worry, it's not that bad. The next thing that happens is actually we're start dealing with the nerve themselves. So basically we have 3 nerves to deal with. The first of them is this one. The largest nerve in our body called the sciatic nerve. And if you look closely, it actually has contributions from the upper parts of the roots and then from lower parts of the roots. And you can actually distinguish 2 components here, which we'll separate later into the common peroneal nerve and the tibial nerve. But right now, they're still getting along together as a married couple, and they're called the sciatic nerve. And the sciatic nerve itself gives some branches to the hamstring muscles. Okay? which are the antagonistic muscles of the quadriceps. So remember, the quadriceps did this, the knee extension, the kicking. In order to pull back the knee flexion, we use the hamstrings on the back here. So the semimembanosus are the major players, also the biceps. These are the major players in the hamstring group of muscles that are knee flexors. Okay. And they come off directly from the sciatic nerve. Okay, so these are L4, L5 mainly, S1 roots contributing to that movement. Okay, and next we actually go to the we actually are done with movement of the hip. We're done with movement of the knee. Now we're down to the movement of the ankle, basically at the foot. So here we have two main players, or two players. As we said, the sciatic nerve is basically a forced marriage between the tibial nerve and the common peroneal that get along the thigh, but then they decide they can no longer handle this and they have to break up. And actually, if you look in the microscope, you can differentiate the two. Already in the hip, you can already see that there's problems there. But here they officially separate, and it happens here. We're looking at the back. Here the patient is looking forward. We're looking at the back of the patient. So we're looking behind the patient, and around behind the knee, the sciatic nerve separates into the tibial nerve, that is the main posterior compartment nerve innervator. And then we have the common peroneal, which we'll look in a moment when we flip the patient over. So let's start with the tibial nerve itself. So the tibial nerve here innervates the posterior compartment. The posterior compartment is mainly involved in what's called plantar flexion. We're planting our foot in the ground, plantar flexion. So for example, when I stand on my toes, what I'm doing is plantar flexion. You ask the patient to walk on their toes. If they're able to do that, they have 5 out of 5 plantar flexion. The tibial nerve is fine. And the muscles that do it, the main muscles that do it are the gastroc and the soleus muscle. These are L5S1, mainly S1 group. And here we have also to remember the Achilles tendon reflex, which is actually mediated by the gastroc and soleus muscle. So it is an S1 reflex that we're testing. Okay? So sitting in the back here, that's the S1 group. So an S1 radiculopathy will have loss of the ability to plantar flex our foot, and also will lose the Achilles reflex. Okay? So that's the first movement of the foot. There's another extremely important movement that I really ask you to remember, and that is foot inversion. Okay, people in Zoom. Foot inversion. I'm turning my foot inward. So the bottom of my foot inward, medially. And it's a little bit hard to explain all the patients to do these movements to test them, but this movement is actually extremely important. And why? This movement is innervated by the tibialis posterior. It's the muscle that does it is tibialis posterior muscle, which is innervated by the tibial nerve. And why is it so important? The reason that this movement is so important is because this is a pure L5 root nerve. What it means is that if this is involved, this movement is involved, or it's important to know, it will help us localize the region to, for example, the L5 root if this muscle is involved. It will be more clear in the next slide when we talk about the common peroneal. But just remember, the movement of inversion is mediated by the tibialis posterior muscle, innervated by the tibial nerve, L5 root. So this is the second movement of the foot. Now, we're going to talk about the common peroneal. But in order to talk about that, we need to flip the patient over. So here we're looking at the patient. The patient is facing us. Okay? So the root is now meandering forward anteriorly here below the fibular head, which reminds me that I actually am not supposed to use the terminology common peroneal because it's an old term. The new term is fibular nerve. These are the same nerves, and I don't have an answer to why we decided to change it. Old nerve, got peroneal nerve. We should I guess change it if it's here in the textbook, it's the same nerve. The official name is fibular. Okay, so everything that I'm telling is actually wrong. Shouldn't use the term peroneal. I don't know if you read those that you guys don't know that because this is from the old version. So anyway, common peroneal, fibular nerve, same thing. The important thing is that it runs along the fibular head over here. And it's actually exposed to pressure over here. So remember that for what we're going to say in a moment. But then what happens to the common peroneal over here is that it splits into two important branches. The superficial peroneal, I keep saying peroneal, it could be superficial peroneal. Whenever I say peroneal, it's put superficial peroneal nerve and the deep peroneal nerve. Let's start with the superficial peroneal nerve. You see how it's more lateral here? This is important for movement that is inverted. This is extremely hard to explain to the patient how to do. It's kind of, you guys see my hand, I'm turning outward. Now the foot is looking outward. So, inverted, very hard to do. Also, not that important because the same roots that do that are the movements that are much easier to grasp, which we'll see in a moment, that are innervated by the deep peroneal. But it is important for that inversion. And also another thing that comes off it is a sensory branch here, and basically a lot of the sensation on the top of the foot, all this area here, is superficial peroneal. Okay. But more important than the superficial peroneal nerve is the deep peroneal nerve, because that innervates very strong dorsiflexors of the foot. Basically, the opposite of plexus flexion is dorsiflexion, is basically pulling the foot upward. If you don't have strong dorsiflexors, you'll have what's called a drop foot, and you'll trip. You will walk and trip. You hear a story that people tell you that you trip a lot, think about drop foot. So dorsiflexion weakness. Okay? Now, the kicker is that this is also an L5 root. So why is it so important? Now, let's say you have a situation that we'll call to the delivery room because after a prolonged delivery, patient develops a drop foot. So how do we approach it? Because we mentioned a lot of times that what is drop foot is weakness of dorsiflexion. And we also mentioned that this dorsiflexion, the roots that are involved are L5, mainly L5. But we mentioned it along the pathway many times. So how do we know where they're moving in? Well, the approach is from bottom up. We first document that there's actually a drop foot. Okay? So we try to see if there's a drop foot. And then we say, if it's only drop foot, or the other way around, if we find anything else in addition to the drop foot, it cannot be explained just by a lesion of the deep peroneal. Now, regions of the deep cranial nerve are extremely common. For example, even if women who gave delivery for a prolonged period of time, or you can see it in men doing prostate surgery that's prolonged. They sit in stirrups, the legs are up, and there's pressure for a long period of time on the area where the nerve meanders and is compressed on the cervicovestibular head. Remember, these first people are anesthetized. They don't feel that they need to move around, like you guys. But for example, you guys, if you sit like that and you don't move, you're also going to get a drop foot. Because now you're creating pressure on the perineal nerve by crossing your legs. You too. No, you're okay. You're okay. People who cross their legs a lot may develop weakness of their leg deflection. Okay, but without even noticing, you switch, you move, switch legs. You don't sit the whole time. Except if you're in coma or thinking that you don't feel, if you have a circumlopathy, you don't feel the need to move, so that pressure can cause a drop foot. But that will be isolated drop foot. Okay? If we have any further movement, it cannot be explained just by this common perineal. Another example, by the way, is weight loss. There's kind of exposure here of the common perineal nerve. So if we test the examination, if you see any movement aside from the drop foot, we know that it's cannot be common perineal nerve. And the first movement that we'll test is the eversion. If eversion is involved, right off the bat, we know it's not just a deep perineal nerve. It could be something else, but we know that it's something that is on the pathway above. So where could it be? Well, many locations. It could be in the sciatic nerve. Now, when people say sciatica, most people actually have it wrong. When they say sciatica, I don't have sciatica, what they mean is I have a radiculopathy. But there is such a thing as true sciatica. I mean, neuropathy, sciatic nerve neuropathy, it's rare and it's controversial, but there is a situation where the piriformis muscle actually compresses on the sciatic nerve, and so everything below that compression can be weak. And they may go and surgerize, cut through the piriformis, and then apparently some patients get better. But that's kind of rare. But that's another location that can cause a drop foot. Sciatica. Okay? But if we have involvement, for example, in roots that are above that area, so let's say, for example, we have movements of the gluteus, or if we have involvement that is more hip extension, the gluteus maximus, then we know that we're above the sciatic nerve, which we say the sciatic nerve branches more to the hamstring muscle. Okay, so here we have involvement of the hip, so we're going upwards, and that leads us to this culprit, which is the lumbosacral trunk, which is also L5. As you said, the long taper, big head, and you have a drop foot. But in those cases, we'll have also weakness of the hip movement. We may have weakness of the hamstring muscle. We'll have inversion movement. We'll have dorsiflexion movement. So we'll have a bunch of movements. So basically, the higher the movement involved, it helps you better localize. Now, if everything is involved in outside and nothing else, then you say, oh, maybe it's an outside movement. So, I just want to end by one thing that we do very common in the lab, in the EMG lab, is test for the perineal nerve. And this is also in the exam question, so I just want to quickly go over it. But in terms of movement, if you think about it, we did actually what I found. We went over 4 movements of the face, 2 of the knee, and 4 of the ankle. Okay? And we have 2 reflexes. If you think about it later on, it will help you in terms of localization. So let's give an example of this patient that has a dropped foot, and we want to test to see if this is a common perineal problem. So what do we do? So what we do in the lab, in the UNT lab, was that join us, can see, by the way, tomorrow, I can review if anybody has time at Maimonides to want to join us, not to have taken like this. But anyway, what we do is we put an electrode here on innervated muscle by the perineal nerve. In this case, it's the extensor distal nerve, mainly L5 root nerve. And then we stimulate in three locations. Here we have stimulation site, a little bit above it, but below the fibular head, and then above the fibular head. Okay? There's stimulation here, stimulation here, stimulation here. In all of them, we report on the same muscle, and we should expect to see the same response. Remember, physiology is all online. The only difference will be that the stimulation, the response will be closer to stimulation in terms of the graph where it is. I'll show you in a moment. When we're closer, because here it just takes this, it's just this distance that we have to overcome. And when we stimulate here, the distance of the action potential is all this. So it takes a little bit more time. So it's going to be a little bit delayed. But once it reaches, it's going to look exactly the same. Okay, let me show you so it's not that confusing. So here we have three responses, A1, A2, and A3. Let's go back and call names. So here is A1, this is the bottom red for the blue people. The middle red is A2, and the top red is A3. Okay? So let's go back to our EMG report here. So on the top, we have the stimulation at the ankle, and we have a very nice response here. The CMAP, let's put the CMAP here. Very nice response. Okay? And then we can go below the fibular head, we see the same kind of response, same height, looks the same, except it's a little bit delayed. See from one we stimulated, which is the y-axis. So look at the x-axis over here, it's a little bit delayed to compare this to this. Of course it's delayed because there is more distance. Oh, I lost my so there's more distance from here to here compared to here to here. So that's why that's why we see this a little bit delayed. But look what happens when we stimulate it at 0.83, which is above the fibular head. It's here, the red dot, the red space on the red oval shaped spot here, which is above the fibular head. Look what happens to the response. Over here, what happens? The amplitude decrease, and if the decrease is below 50% compared to before, what is it called? Well, conduction block. So we have here a conduction block below, and when we compare the above fibular head to below the fibular head. And so what we have here, and also we have slowing here, I can get there, but anyway, what's really clear here is we have lower amplitude, a conduction block, which means this is electrical proof that we have here pressure that did not allow the stimulation to get through, or at least 50% of the stimulation cannot get through because we have a block, either because we cross the legs too much, or the regular stirrups, or some exam question 238. So remember it. So when you get to question 238 on the board, remember it's induction block. Any question? All right, please review by movement. The same goes for the upper limb. And please remember your EMLS. Okay? Zoom people, any questions? I guess not. Okay. All right. Sure.
Thank you, Robert. Yeah.
Sure.
Go back.
Oh, thanks.
So here, continue to, continue something today, that we did have only lessons in one classroom.
Yeah, I was not.
Unless we do it in the workroom on the seventh floor. So we're saying workroom on the seventh floor unless classroom, whatever. Insist on that.